A very good evening to one and all. Thank you so much for joining the session today. Apologies for the delay in starting our session. We had some technical issues because of which we had to slightly delay the presentation. So today we'll be having the fifth presentation of cycle 2 of basic module in infectious diseases. And before we move on to the presentation, I have a few pointers to discuss. This is mainly for the participants who are viewing this presentation today. Satya, could you change your slide? So you can post any questions that you have during the presentation. There is an option for you to post the comments or questions in the website. And these questions will be discussed during the Q&A session at the end. The feedback button is also available below the comment box. So these feedback forms will be disabled after the live session. You can claim your certificate within 14 days after the event. The certificates will be issued. And in case you're watching this event on YouTube, please log into the website in order to claim your certificate. You can also download your slides. These presentations would be available as PDF from the website, but you need to log into the website to download the material. Next slide. Okay. So with that, I would like to invite our speaker for the day, Dr. Satyanarayana Reddy. He is working as antimicrobial stewardship clinical pharmacist at Venus Hospital, Surat. And today he'll be discussing about duration of therapy. And to just speak a few words about Satya, he has been working at Venus Hospital for the past 1.5 years, and he is currently actively involved with various antimicrobial stewardship initiatives and quality improvement projects in his hospital. Some of his key areas of interest include PKPD. And so without any further delay, I would like to invite Satya, and over to you.
Yeah, very good evening all. Thank you for your kind introduction, ma'am. Without any delay, I'll start. Yeah, I don't have any relevant financial relationships with any commercial interest. And today, learning objectives of the session would be like, what does the duration of therapy mean, and how this duration of therapy differs with days of therapy, and also what are the different kind of therapies, and how based upon the syndrome, I mean systemic approach we'll be following, and how this AMS impact the duration of therapy, how the antimicrobial duration is associated with the cost of the therapy, and also what are all the roles a CP can do on rounds. Definition. Before going into definition, I just want to give a short note. Like if you know about this AMS, there would be 5 Ds. The first D stands for appropriate diagnosis. The second D stands for the drug of choice. Third D for dose, and fourth D for the duration of therapy, and fifth D the appropriate de-escalation choice. So if you look across these 5 Ds, the fourth one is duration of therapy. So this is the importance of duration of therapy in AMS. It can't be complete without this. So that's why it has a good kind of importance in implementing AMS. And next thing, what does the definition mean? The duration of therapy refers to like how long a patient need to be treated with the specific treatment for a particular clinical condition. And how does this differ from days of therapy? See, days of therapy, nothing but it is an AMS quantitative process indicator. Here, the most of the time we will be talking about how many antibiotics, I mean, the total number of days a patient receives at least one dose of antibiotic throughout his regimen, throughout his course therapy. And this example will give you a clear idea. For example, there are three conditions. The patient one is on ceftriaxone 1 gram QID 12th hourly for 7 days, and metronidazole 500 mg OD for 5 days. And the second patient on ceftriaxone 1 gram 12th hourly 5 days, and metronidazole 500 mg for OD for 5 days. And third patient is on ceftriaxone IV 12th hourly for 7 days. So if you observe here, we'll be calculating the total number of ceftriaxone doses went for particular patient throughout his therapy. So this way, we'll be calculating number of doses of ceftriaxone went throughout month. Same with metronidazole. The total number of metronidazole doses went for particular days. So this way, it differs from duration of therapy. I hope you understand this. Like now we will be knowing how the concept of days has been added to the therapy. See, it was started in India by during Shalivahana period. The person is Shalivahana, and also one more Emperor Constantine. He is from Rome. These two people started linking the days with the planets. So from there, they started during their ruling time. They started linking the number of days with therapy to remember like how many days the therapy was went, how many days the therapy need to be still given. So this way they correlated. And what are the categories? So here we can learn about preemptive therapy, prophylactic therapy, empirical therapy, and definitive therapy. Firstly, we'll be talking about prophylactic therapy. Prophylactic, nothing but it's the Greek word, nothing but a preventive measure. Generally, this word you'll be listening during your surgical prophylaxis monitoring time. Nothing but you are giving an antibiotic dose for preventing the upcoming any adverse event or any risk factor. And next, empirical therapy. See, empirical therapy, same, it's from Greek word. And here the antibiotic therapy would be started based upon patient signs and symptoms, objectives that were observed, I mean, like on the in the presence of patient. And also there would be no evidences available, like lab investigations, radiology reports, any culture reports, this way. And preemptive therapy. Preemptive therapy is almost equal to this empirical therapy. But here the difference is, here we will be targeting only high-risk patients. For example, a patient who is undergoing hemopoietic stem cell transplant or any kind of organ transplant, or if a patient is prolonged duration of therapy on chemotherapy. So for these patients, there would be more chance of failure in immune system because all these patients would be already will be on immunosuppressants. This will inhibit the stimulation of our immune system, which will help the bacteria or infection to grow rapidly. So for these selected patients, this kind of therapy would be initiated. Definitive therapy. It is an exact targeted therapy, and also definitive therapy is also called as targeted therapy or therapeutic therapy. It is a French word. Generally, we'll be selecting this kind of therapy with all the kind of evidences. For example, lab investigation, culture reports, radiology, patient biomarkers. So this will help to take an exact therapy, which will help in narrowing the therapy also. This is a small glimpse like what are all the considerations will be available. For example, prophylactic. Here we'll be only knowing the risk factor. For example, if any patient is undergoing orthopedic surgery, then we only can know what is the area he is undergoing surgery and what would be the bacteria that would cause SSI, I mean surgical site infection. So in this way, we'll be correlating with risk factors and we'll be designing our prophylactic therapy. When dealing with preemptive therapy, here we will be having both biomarkers and risk factors data. And same with empirical therapy, here we will be having clinical signs and symptoms and documented signs and symptoms and also risk factors, what the patient have in his past medical history and all. When it comes to definitive therapy, here every factor would be available so that we can design our regimen based upon the clinical condition. It is a syndromic approach, like we can now explore in detail. Meningitis. The common meningitis, the common kind of differentiation we can make is, see, there would be two kind of meningitis, community acquired and hospital acquired. In community acquired, the most commonly prevalence we have regarding the organism is Streptococcus pneumonia, Neisseria meningitis. These two are more common in community settings. While coming to hospital acquired, it would be Staphylococcus aureus, Neisseria meningitis, and also Streptococcus. Yeah, community acquired meningitis. While we are dealing with meningitis and with bone and joint infections, the duration of therapy differs based upon the organism that is causing infection. For example, if it is listeria, it would be 21 days or more than 21 days. For Haemophilus influenza, it would be 7 days. And the Streptococcus pneumonia, 10 to 14 days. Neisseria would be 7 days, and Streptococcus agalactiaceae would be 14 to 21 days, and for gram-negative bacilli it would be 21. All the bacteria that are represented in a purple color would be gram-positive, and all represented with a pink would be gram-negative. Yeah, hospital-acquired infections. As I previously just discussed, Streptococcus group. In this, the viridians, the gram-negative group would be more prevalent group that would be causing hospital-acquired. And regarding next, the MRSA, Staphylococcus aureus. So for these two, the duration of therapy would is same, like 10 to 14 days. For gram-negative bacilli, it is 21 days. It would be like Haemophilus influenza or like Pseudomonas, whatever it may be. Same. The meningitis also would be occurred because of fungal involvement. The most common one is cryptococcal pneumoforms. Here, the duration of therapy would be divided into three phases. One would be induction phase, consolidation phase, and maintenance phase. In induction phase and consolidation phase, it will last long around 10 to 12 weeks. This would be mostly to suppress and make the patient to recover fast. So this is the main aim of this induction phase and consolidation phase. Whereas maintenance phase, if you observe clinically, this cryptococcus meningitis would be one of the complication in HIV patients. So that's why if the patient is having any complication of HIV, it must be like 12 months of maintenance therapy. So then only the complete eradication of bacteria would be done. And next, the CD4 and CD8 levels, CD8 levels need to be monitored. Coming to viral encephalitis, the common virus that causes the encephalitis were herpes simplex virus. That is, the duration would be like 14 to 21 days. And varicella zoster, same. It would be same 10 to 14 days. And cytomegalovirus. This cytomegalovirus is an like commensal of our body. Whenever the immune system gets suppressed or whenever the immune system falls goes down, this will start getting dominating our body, and it will start replications, and it will increase its daughter cells and production of its cells. The induction phase would last for 2 to 3 weeks, and if the necessary maintenance phase is required, it would be same again 2 to 3 weeks. Yeah, coming to respiratory infections, here we'll be dealing with two kind of respiratory infections. One would be involving or dealing with upper respiratory tract, and next would be lower respiratory tract. Upper respiratory tract would include tonsillar pharyngitis, sinusitis, acute otitis media, and lower would be respiratory tract infections would be more our everyone knows familiar with this community acquired pneumonia, hospital acquired pneumonia, ventilator acquired pneumonia, or COPD. Regarding upper respiratory tract infections, I want to add a note here. Most probably the upper respiratory tract infections would be because of virus. The common virus would be rhinovirus, adenovirus, enterovirus, influenza virus. So most probably, unless and until there is no evidence of bacterial growth, we should not go for antibiotics, because antibiotics works against bacteria, not virus. So that is one of the important point we need to keep in mind while we are dealing with respiratory tract infections. If it is proven a bacterial infection, then we can go ahead with including the antibiotics into regimen. Like tonsillopharyngitis in children and adults, the penicillin V, it is available in oral form for 10 days. And another option is third generation cephalosporin like ceftriaxone plus azithromycin, an atypical coverage for 3 to 5 days. Next thing, because we are adding this atypical coverage, most probably if you cross-check with community-acquired respiratory tract infections, it would be atypical bacteria that would be causing the infection. That's why. And otitis media in children and adults, if the age is between 6 months to 2 years, it is 10 days. And if the age ranges 2 to 5 years, 7 days. And if the age ranges greater than 6 to an adult age, like 18 to 24, the duration of therapy would last for 5 to 7 days. Bacterial sinusitis, if it is children, 7 to 14 days. And if it is adult, 5 to 10 days. These are the incidents like which bacteria can cause what kind of pneumonia. If you consider community acquired, just now we like the most common cause of community would be atypicals. The involvement would be by mycoplasma, chlamydia. Other than that, streptococcus, hemoinfluenza virus, hemoinfluenza, all these would be the incidence of bacteria that is causing community acquired pneumonia. Whereas coming to hospital acquired pneumonia, It would be like Klebsiella pneumonia, Pseudomonas aeruginosa, Acinetobacter baumannii, Enterobacter erogens, or Enterobacter cloacia complex, or Streptococcus aureus. All these are the listed bacteria. This is one of the important aspect to remember while we are dealing with community acquired pneumonia. Even it is severe or non-severe, even patient is an outpatient or inpatient setting patient, we need to only prefer for 5 days. If you target dealing with this disease, you need to go for 3 to 5 days of therapy, not greater than this. But when there is an involvement of Pseudomonas or Staphylococcus aureus that is resistant to methicillin, then you need to go for extra 2 days, because these two bacteria have a good kind of resistant mechanisms that can develop easily. Even one dose exposure to this bacteria can develop a good kind of resistant patterns. That's why they need to be treated completely. So this is the reason why we are going for extra 2 days. And the criteria for stopping or converting IV to oral would be like the patient need to be affable, and the heart rate need to be below 100, and its BP, like systolic, need to be less than 130, and diastolic need to be less than 90. And also the partial pressure of oxygen in arterial blood vessels should be greater than 94, and the respiration rate need to be less than 20 to 20. All these are important factors that we need to keep in mind while we are stopping or while we are converting from IV to oral. If you find at least greater than one symptom, like patient feeling or patient discomfort, and if he is not hemodynamically stable, then we need to go for extra 2 days and need to correlate with patient condition. And now hospital acquired pneumonia or ventilator acquired pneumonia. See, when we are dealing with this, this is one of the common kind of indication or condition that in every MIC settings, MICU settings. So the main reason is the breach in infectious practices, I mean infection control practices. If these were maintained well, that would be first step to prevent hospital acquired or ventilator acquired pneumonia. And the common bacteria would be Pseudomonas aeruginosa, if not Acinetobacter baumannii. These two would be predominant. That would be causing HAP or VAP. And the duration of therapy would lie less than 8. And next, if we are dealing with any non-fermenting bacteria, for example, Acinetobacter baumannii, Pseudomonas aeruginosa, Stenotrophomonas maltofia, or Burkholderia cepacia. So all these kind of bacteria are very complicated bacteria with good kind of developing resistant mechanisms. So that's why a monitoring of a patient for every 48 to 72 hours regarding their medical response, I mean their clinical response, need to be monitored. And also, as per the current guidelines, they are also asking us to monitor the PEEP values. If a patient is mechanically ventilated, we need to monitor the PEEP value, and also FiO2 and PaO2 ratio. So this is also one of the important factor that to take decision apart from radiology. And COPD. Everyone knows like COPD will be the gold standard guidelines would be gold initiative for chronic obstructive lung disease. This says that if there is involvement of following symptoms like increased in sputum plurulence, or any kind of shortness of breath, or a productive cough, or increasing in thickness of secretions, or prolonged secretion of prolonged production of secretions, this may shows a kind of risk factor. So for these patients, we need to add antibiotic initiation into their therapy. More than two or three symptoms from the listed above symptoms, in those patients, we need to go with initiation of antibiotic therapy, and also patients who are mechanically ventilated. Influenza. See, influenza is a viral kind of infection. The drug of choice would be oseltamivir, like everyone knows. BD, it should be given for 5 days. In immunocompromised patients, it is like 7 days. This is also one of the important factor. For influenza, it would be most probably the upper respiratory tract infection again. So should not deal with antibiotics. This way, at least we can stop misuse or overuse of antibiotics, which would be helpful in decreasing the resistant rates. Next one, endocarditis. Yeah, this is also one of the important one. Endocarditis is nothing but an infection to walls or the inner lining of an heart. The most probably the bacteria that are responsible for endocarditis are streptococcus. These are all common. There are few common species that are kind of commensal in our oral cavity also, like Streptococcus mutans. So these are all the things. Next thing, Staphylococcus aureus is also one of the important bacteria to talk. Enterococcus and gram-negative bacilli. These are all the indications where a prophylaxis need to be given if a patient is having a complication of endocarditis. For example, if a patient have an history of bacterial endocarditis, and also if a patient underwent any kind of CABG surgeries recently, and also if a patient is having any heart diseases, and also if a patient is undergoing any dental surgeries or any like a root canal replacement, all these things we need to go for prophylactic dose, because these may have a risk factor of forming of an infection due to this endocarditis or streptococcus mutants that are common commensal of our oral cavity. The prophylactic therapy is like amoxicillin. For adults, it would be 2 grams, and if it is children, it would be 50 mg per kg. If the patients are allergic to penicillins, we can go for clindamycin. If it is children, 20 mg per kg, and if it is adult, 600 mg, only stat dose. That need to be given at least 1 hour before the surgical procedure. Yeah, this is one more important guidelines. When you are dealing with the endocarditis, the thing is, if blood culture shows positive from that day to next 4 to 6 weeks, the therapy need to be continued. And if a patient is on any kind of catheters, they need to be removed, because the complication here is, for example, if you take Streptococcus species or Staphylococcus species or Pseudomonas aeruginosa, all these can form biofilm. So which makes another complication, because all antibiotics can't reach cannot cross the biofilm and can help in treating the patient. So that's why if a patient is on any central lines or any kind of catheters, those need to be replaced. And next thing is cardiac related infections. I mean, if a patient is having any pacemakers or any kind of generating devices. For example, if a patient is having a complication of arrhythmia, in those patients, there would be pacemaker or any kind of generator leads, which helps in maintaining the heart rhythm in a normal range. In those patients also, even though the culture shows positive, the kind of prophylactic and also therapy need to be given for 10 to 14 days. And if there is a visitation, that also with an evidence of transesophageal echocardiogram would be the kind of thing used for knowing the vegetation in these patients. So based upon that evidence, we need to go for 4 to 6 weeks of therapy. And also, if there is any involvement of prosthetic valves, we need to go for 6 or greater than 6 months of 6 weeks of therapy. Sorry. Yeah. Intra-abdominal infections. See, this is one of the important point that we need to remember as a CP. Whatever it is, whichever organ it is, if there is any involvement of abscess or any kind of purulence or pus secretions, the first thing we need to do is source reduction or source control. Then only the duration of antibiotics will depend and will vary. Unless and until there would be no worthy of adding antibiotics if there is no source control. This is one of the trial that was done in 2015. They tried in with 2 groups. One is control group in the sense the traditional group which they are following with the normal treatment guidelines, and one more group is experimental group. Here they have tried with new interventions. For example, with a good proper source control, the control group underwent 8 to 10 days of therapy, and the experimental group underwent 4 to 5 days of therapy. Here, there were same clinical outcomes, even though the therapy was shorter. There was same clinical outcomes, and also the patient mortality rate and recovery rate was same. So by this, we can just make sure that how important the source control is. For example, in few complications, like where we can't do a source control completely. For example, if there is any involvement of GIT or any involvement of like upper respiratory tract, sorry, the organs that are present above diaphragm. So in those conditions, we need to decide the therapy based upon the patient clinical outcomes. So yeah, same thing. The source control should be achieved first. Then only the days of therapy would be showing a good kind of, I mean, it would add a worthy to your days of therapy with short course. Even if it is same for appendicitis, even if it is complicated or uncomplicated, 4 to 5 days of therapy with good source control practices. And for these patients who are on drains or any kind of lines or catheters, a good infection control practices need to be implemented on ground, because those are also one of the important factor which may cause or create a complications to the patients, which can increase length of stay, economic burden, and also complications. And if you cross check same, pancreatitis, it is 5 days. Diverticulitis 5 to 10 days. Heliobacter pylori infection, a triple therapy that would be given 10 to 14 days. Salmonella typhi 7 to 10 days. If a patient is immunocompromised, it would be 14 days. Same non-salmonella involvement, then would be 7 to 10 days. And C. diff 10 days, amoebiasis 7 days. Coming to urinary tract infections, it is like, again, we'll be dealing here with two kind of infections. One would be upper urinary tract infection, and second would be lower urinary tract infection. Lower urinary tract infection, nothing but it includes cystitis, prostatitis, and also urethritis. While upper urinary tract infection, it include like pyelonephritis, urosepsis, ureter infections. And also these recently there were one more guidelines. They are saying like they have differentiated the complicated and uncomplicated UTI into two categories. One is any infection other than cystitis is called as an complicated infection, complicated UTI. And any infection that is having involvement of alone bladder or the indication called cystitis, it is called acute or non-complicated. These are all the few clinical scenarios we need to keep in mind while you are doing your or while you are going for your rounds. When a patient have no symptoms, but if the patient urine positive, I mean urine RM shows positive for pus cells, RBC, glucose, then we should not treat the patient. I mean, there should not be no initiation of antibiotics. We need to monitor the patient thoroughly. Next thing, if a patient presented with signs and symptoms, then it would be like a symptomatic criteria. Now, if there is any again add-on of evidence like positive urine analysis, like same having a pus cells, WBC or glucose in their urine sample, then we need to initiate antibiotics. While if it is pregnant woman, the complete scenario would be different, because even though the patient was asymptomatic with a positive urine RM, like pus cells involvement, we need to start antibiotic therapy because it may turn into pyelonephritis or any systemic infections. Very soon, it may affect the fetal growth also. Yeah, cystitis was divided into complicated and uncomplicated. Here we'll be talking about if it is uncomplicated, we'll be excluding the kind of complications. For example, if there is no abnormality in urinary tract, and if there is if the patient female patient was not pregnant, in those patients the duration of therapy would be very short. For example, if you take trimethoprim sulfamethoxazole, it would be 3 days. Nitrofurantoin, BD dose 5 days, beta lactams 5 to 7 days, phosphomycin stat dose. If you observe why these beta lactams are prolonged, I mean, going for a long duration in the sense, these beta lactams are hydrophilic antibiotics. They won't stay, they won't be distributed to the tissues very rapidly because their volume of distribution is very low and their systemic concentration would be high. Whereas in case of lipophilic antibiotics, the volume of distribution would be high and their volume of, I mean, the penetration to tissues would be more. So that's why while you are going for beta lactams or any kind of hydrophilic antibiotics, we need to go for prolonged infusion for maintaining antibiotics concentration in a plasma above MIC for treating the infection. Pyelonephritis or urosepsis. Yeah. Here urosepsis is nothing but the infection reached to tissue, that is nothing but kidney, and then it was spread to systemic circulation. It can be called as a complication, double complication. So when you are dealing with these kind of indications, we need to keep in mind the antibiotic need to have good kind of penetration both into tissue as well as systemic circulation. I mean the peripheral compartment and also the central compartment. That's why if you take these fluoroquinolones are lipophilic antibiotics, and its distribution would be more in tissues. So that's why we are going for 7 days. And beta lactam same, prolonged 10 to 14. As trimethoprim and sulfamethoxazole are slight lipophilic, that's why it doesn't show much greater impact. We'll be going for 14 days. In immunocompromised patients, it would be 10 to 14 days. And always we need to keep in mind that while we are going for any kind of empirical therapy, we need to start with by keeping in mind about the local epidemiology resistant patterns of bacteria. Catheter associated or catheter related UTI. If a patient is symptomatic, change the catheter, and then the therapy need to be continued for 7 days. If there is delay in therapy or if there is no response, then we need to increase the kind of duration from 7 to 10. Even if there is no response, 10 to 14. And this is one more practice that they are saying. If your catheters were having kind of application with antiseptics like silver kind of compound or any kind of chlorhexidine, normal saline, the chance of having or the chance of occurring COTI would be very less. Skin and soft tissue infections. Here, same. If you deal with cellulitis, the cellulitis without any pus, I mean, any incidence of purulence, then the duration would range from 5 to 6 days. But if there is any kind of evidence that patient is producing pus, purulence, drain, then you need to go first for source control, that is source reduction, then followed by antibiotic therapy. It varies as per the condition. And erythrocytes, it is 5 days. Again, same. Necrotizing fasciitis. If you observe the same thing, wherever you find this kind of debridement or source control, that thing, but there is an involvement of forming of pus or any kind of dead tissue or the kind of increasing of bacteria. So that need to be first eradicated, I mean, removed. Then only the kind of antimicrobials or antibiotics involvement would play a good role in giving and good outcomes. In immunocompromised patients, it would be 7 to 14 days. Same for diabetic foot. See, wherever like GIT, skin, all these areas are most probably depending upon source control. After that, we need to decide the duration of therapy. In diabetic foot, if the infection was spread only to the upper superior layer of skin, then it would be 3 to 5 days. If the infection penetrated till the connective tissue, then we need to go for 1 to 3 weeks. And if it reached till bone, it would be 4 to 6 weeks. Like carbuncles and furbuncles are 5 to 7 days. And in any kind of immunosuppressant patients with skin and soft tissue complications, it would be 7 to 14 days. Same for acute bacterial, I mean, skin and soft tissue or skin and skin structural infections. First thing is source control. Then the choice of antibiotic decides the days of therapy. Linezolid would be 10 days, tedizolid would be 6 days, dalbavancin 1 dose stat, and also retavancin 1 dose stat. Dilafloxacin, it is an advanced levofloxacin, 5 to 14 days. Again, the same thing. The advantage of this levofloxacin, sorry, fluoroquinolones is they will be having good kind of bioavailability. So we can easily switch to IV to oral if a patient is eligible for the shift. And one more important point, whenever we are dealing with skin infections, the point we need to give a thought is like there would be an involvement or there would be a risk of anaerobes involvement. So to deal with that, we need to add clindamycin or the main reason why clindamycin added is this would be having good antitoxin production. I mean, the anaerobes will be producing an enzymes that acts as an toxins on the skin and that will degenerate or that will damage the skin. So for preventing that kind of scenario, the clindamycin would be having good toxic inhibition property. So that is the important role of clindamycin in anaerobes while we are covering anaerobes. Fungal skin infections. Same, like onychomycosis, it is 3 to 6 months. Candidiasis, it is 14 days. Aspergillus, it would be 6 to 12 days. Mucormycosis, 4 to 6 weeks. And again, the same point, wherever there is an involvement of deep infection, source reduction is an important, which helps in decreasing the duration of therapy. Bone and joint infections. Same here also the primary management would be source reduction. The source reduction is very important thing in all these things, because when we remove all the bacterial load or bacterial kind of drain that is present at infection site, then it can, it can easily respond to the antibiotic therapy. So that is the secret behind this. That's why they are mentioning, so stressing the source control as a main point in all these infections. If there is any staphylococcal management, the first thing is, uh, all knows, first we need to know what is the cause for it. So for that, we need to, for example, if a patient is already having an implant, yeah, if the patient underwent any implant surgery, for those patients, if there is an incidence of SSI, first thing we need to do is debridement, and also irrigation of that particular site and implant retention. If you take any joint or bone infections, there will be a good involvement of rifampicin. The reason is it has good bone penetration. That's why maximum you will be finding the rifampicin involvement in each and every joint and bone infections. And the duration of therapy will be 2 to 6 weeks. Without rifampin, it would be 4 to 8 weeks. Same. If there is any involvement of hip or elbow or shoulder, the therapy need to be given for 3 days, 3 months. And if it is knee prosthesis, then it will be 6 months. The reason why the bone infections are taking much time to recover means, for example, if you come across the word osteoblast, the production of osteoblast would be very slow. So that's why the immune system and followed by the production of osteoblasts would also decrease with the increase of age. So this is one of the risk factor if this occurs in aged persons. So the kind of recovery would be very slow. Yeah, second is replace. First thing, in a first stage, we need to give 2 to 6 weeks of rifampicin. In absence of rifampicin, it need to be 4 to 8 weeks, and followed by de-escalation. The first and foremost point we need to remember is, while we are dealing with bone and joint infections, minimum of 4 to 6 weeks of IV therapy need to be given. Minimum 4 weeks. Then, if a patient is eligible for paroral, then we can switch as per the good bioavailability de-escalation choice. And same in removal, we need to remove the kind of implant that was inserted there and need to be re-explored. And the treatment would be 4 to 6 weeks. And if it is non-staphylococcus management, amputation need to be done. If there is no kind of source control possible, then the choice would be amputation. That would be more common in diabetic foot infections. And also the duration of therapy is 4 to 6 weeks. Tuberculosis. This is also one of the important risky disease which is causing deaths, or which is increasing the mortality rates. Here, the tuberculosis is such a kind of bacteria that enters into the cell and starts infecting and completely destroys the liver, lung tissue. So this way it spreads its infection throughout the lung. Um, Regarding duration of therapy, if it is like intensive phase for category 1, the heads therapy would be added. Here H represents isoniazid, R represents rifampicin, Z represents pyrazinamide. Sorry, there was mistake. And E represents ethambutol. It is during intensive phase. And continuous phase, we need to exclude both pyrazinamide and ethambutol. We need to only go with isoniazid and rifampin. While if it is a category 2, here we need to give an addition of streptomycin also for 2 months, and followed by 1 month of HEDS therapy as mentioned above. And next, followed by the continuation phase, would be 5 months of isoniazid, rifampin, and ethambutol therapy, a combination. Continuation phase differs as per indication. See, based upon the bacterial invasion and also based upon bacterial site of infection, the course of therapy would differ. If it is pulmonary involvement, it would be 4 months. If it is extrapulmonary, like brain or different liver, all these organs, it would be 6 to 10 months. In HIV, it is also one of the complication which would be seen as an opportunistic infections. So for them, it is 7 months. If you observe, even after intensive phase, if the culture shows positive, again you need to go for 7 months. So this is one of the important point we need to keep in mind. Latent TB. Everyone knows active TB in the sense it can spread from one person to another person from an infected person. and it will not cause any signs and symptoms to an infected person, but it will cause and symptoms, sorry. And latent TB in the sense there would be no signs and symptoms, and there would be no advancement of kind of worsening of a patient condition. And it is important that in this patient, it need to be treated. If it is not treated, it can get to an advanced level, which can be like a complete, it is a kind of period that a bacteria takes a time to completely grow and rupture. So once it starts rupturing and replication, it's impossible to stop. So that's why we need to start a kind of therapy initially. For a latent therapy, the kind of therapy differs. If it is isoniazid alone, it need to be like 6 to 9 months. And if it is rifampicin plus isoniazid, it would be 2 to 3 months. Rifampicin and isoniazid combination would be for 3 months. Rifampin alone 4 months. Same. The continuation phase differs based upon the site of infection. So because the penetration and also the kind of recovery, all these things differ from system to system. If it is skeletal TB, 7 to 10 months. If it is tubercular meningitis, it is 7 to 10 days. Pulmonary TB, it is 4 months. If it is any involvement of lymph nodes, then it would be again 4 months. Yeah, sexually transmitted diseases. The common bacteria that are responsible for sexual transmitted diseases are chlamydia and gonorrhea. See, if you cross-check this chlamydia and gonorrhea, the duration of therapy would be same. But when you take the kind of conditions, the disseminated infection, disseminated in the sense, the kind of infection would be spread or would be like reach to different organs, surrounding organs are throughout the body. So in those patients, if it is like gonococcal meningitis, 10 to 14 days. And if it is septic arthritis, 7 to 14 days. And if it is gonococcal endocarditis, 4 weeks as usual. And if it is syphilis, the primary, secondary, and early latent during these phase, the benzathine penicillin need to be given stat IM. And if it is late latent phase, then same antibiotic need to be given once in a week for 3 weeks. If there is any involvement of neuro or ocular syphilis infection, then we need to go for aqueous penicillin for 10 to 14 days for TID because it has a less half-life. And also our alternative is like alternative nothing but if a patient is allergic to penicillins, we will be going for an alternative therapy for primary and secondary and early latent period phase, doxycycline for 10 to 14 days. If it is late latent phase, doxycycline for 28 days. Yeah, the pelvic inflammatory disease would be 14 days. This is one of the viral diseases. This is common one, like everyone, 3 among 10 or 3 among 20 people would be seeing this. These are called, the common symptoms would be warts. These warts are due to the unhygiene or any kind of friction that happens rapidly. So for this also it would happen. The kind of treatment would be equimoid cream. It is available in 2 doses, 3.75 and 5%, need to be taken for 16 weeks. And podophylox cream at 3 days BID dosing. Herpes simplex virus. Like the first drug of choice would be acyclovir. If it is not available, valcyclovir and famiciclovir also available. Same, whatever the drug you select, it need to be given for 10 days. If there is a recurrent or relapse, then we need to go for against acyclovir for 5 days, BD dosing. And if the dose is less, we need to go for TID. And valcyclovir, 1 gram for 5 days OD dosing. And if it is 500 mg, 3 days BD dosing. And famciclovir, if it is 125 mg for 5 days BD dosing. And if it is 250 mg for 2 days BD dosing. And if it is 1 gram, 1 day BD dosing. And this is one of the important thing where a clinical pharmacist also have a role in surgery department, surgical antimicrobial prophylaxis. So almost same here, the infection control breach also may lead to surgical site infections. Based upon the surgery procedure, the dose, drug, duration will depend. For example, if you are dealing with the clean surgery sites, then there is no such kind of prolonging the therapy. Just one dose or just within 24 hours, we can stop the surgical prophylaxis regimen. And one more thing we need to keep in mind is the antibiotic dose need to be given within 60 minutes if it is time dependent antibiotic. If you are going for a concentration dependent antibiotic, then you can consider till 90 to 120 minutes in case of vancomycin, whereas this levofloxacin, all these things. And also, if a procedure of an surgery prolonged greater than 3.5 hours or 4 hours, we need to go for redosing. Also, we need to cross check with blood loss. If there is more loss of blood greater than 900 ml or 1500 ml, between this, we need to go for redosing, because here the IV dosing, if it is if the blood is removed or if the blood is lost, the concentration of an antibiotic will decrease in the body. So that's why we need to think for redosing. This is also one of the important factor as a CP role. The most common antibiotic preferred would be cefazolin. If it is not available, cefuroxime is also fine. And one more thing is, based upon the kind of surgery site, if it is contaminated, the kind of coverage would differ. If it is dirty, the kind of coverage would differ. So that would differ based upon the patient and surgery site. Yeah, above all, this is one of the important again for whoever are going for rounds as a CP. The thing is, the study is showing that the randomized clinical trials, around 103 randomized clinical trials, are saying that the shorter course is also showing the same benefits and same clinical outcomes as when we compare with the long course of therapy. So that's why this is one of the, not now, almost 4 to 5 years before this was started, but it takes time. The resistance is from the kind of environment, the place where we are working, and also the surgeons, physicians. We need to provide them an evidence-based medicine. Then they would be like at least receiving the kind of inputs we are taking. So we always need to monitor what is the days of therapy and what is the patient response and how the bacteria would differ the days of therapy. So these three things again need to keep in mind while you are preferring this shorter course. This is one more new mantra that everyone are saying, like oral would be also new IV. Why? Because if you at the time of de-escalation, the fifth D of AMS, we'll speak about this only. At the time of discharge or at the time of de-escalation, if you select the antimicrobials with good bioavailability, then the kind of efficacy would be same when we compare with the IV agents. This is the data of osteomyelitis. If you see here, there were 9 randomized clinical trials that were conducted. Among that, there were same clinical outcomes. 84% of population were recovered and having good clinical outcomes compared with the IV. It is 83. So almost same and even more compared with the IV. Is the importance, like if you select a good antibiotic which is having good bioavailability with a good post antibiotic effect, would be having same outcomes would be achieved, and also the kind of burden would be decreased on patient. Bacteremia, here the most probably same 12 randomized clinical trials were done. Among them, the 82% population was having good clinical outcomes, and when we compare with IV, it is 79. So again, here we have a good kind of evidences that selecting good selecting good antibiotic with good bioavailability will help in getting or acquiring good clinical outcomes. And this is data on endocarditis. There were 3 randomized clinical trials that were saying that the oral antibiotics are giving a good kind of efficacy, like up to 77 population were having good clinical outcomes. When compared with IV, they are only 70. So here also the kind of oral antibiotics are dominating. Same for intra-abdominal disease. First thing, whatever it is, you need to focus for reduction, then followed by antimicrobial regimen. So same, the 5 randomized clinical trials are saying that 82% of population were having decreased in mortality rate and also increase in clinical outcomes when following the oral therapy compared with IV. Yeah, this is one more same urinary tract infections. 4 randomized clinical trials are saying 89% of good outcomes were achieved with an oral antibiotics when we compared with IV antibiotics. Yeah, now it's an linking of like how AMS can impact the duration of therapy. See, I mentioned earlier, when we take an AMS, there are 5 Ds that are most important for making it rational approach. missing of even 1D or not giving an importance to even one kind of D will not give you a complete AMS approach, complete rational AMS approach. So for this, what are all the interventions or what are all the things we can do by implementation of AMS is like you can start antibiotic timeouts. For every 48 to 72 hours, you need to monitor what is the patient outcome, how the patient is responding to the therapy, and what way. I mean, is there any kind of chance to escalate or de-escalate the choice of drug? And next thing, pre-authorization. This is one of the important factor. This is implemented in our hospital. This helps in decreasing the irrational use of reserve antibiotics, the high-end antibiotics, because those antibiotics, list of antibiotics are the last resort drugs for multi-drug resistant organisms. So those need to be preserved. First, we need to start with access group, next watch, and followed by reserve. Until and unless there is no necessity, we should not go for reserve group. So this way, the pre-authorization form is like documentation of why the purpose of using reserve antibiotic is necessary and what is the reason for it, what bacteria or what kind of thought is giving to start with reserve antibiotic. So this way we'll be taking on feedback from intensivists, most probably intensivists, and that would be escalated to treating physicians. So this way it helped us in our settings to decrease the misuse of reserve antibiotics. And one more, pharmaceutical interventions. Here it includes regarding the duration of therapy, you can correlate with the IV to peroral switch. How many days the patient is on IV and how many days the patient was at what day the patient was switched to oral, and what is the clinical relevance between both two. That also we can calculate. And also duplication therapy, which will again cause a complication in a patient, which is unnecessary. Exposing of antibiotics, which may again cause developing of resistance within the microorganisms. Automatic stop orders for certain diseases. Sorry. And also infection specific. If you take infection specific things, for example, community acquired pneumonia, just now I have mentioned, you need to consider the inclusion criteria where you need to think for initiation of antibiotics. If it is like COPD, the purulence, thickness of purulence, the production of pleural secretions, and also the shortness of breath, mechanical ventilation, all these complications will help in all these complications will again give a thought for continuation of treatment. If there are no signs and symptoms, we can de-escalate or we can stop the therapy even. Because if you continue giving or if the patient get exposed to high antibiotics, there is a chances of developing Clostridium difficile infections, which is again one more complication. This is one of the important theory, like I feel important because HEOR nothing but see, I just want to start with the basic. If you take diagnostic stewardship, antimicrobial stewardship, and infection control practices, these three are like three systems. These need to function at one line. Then only every contribution has a value. If there is a breach of any practices in one segment, there would be again an imbalance in complete approach. So that's why these three need to be at one platform, and these three need to be given at a full attention. And coming to HEOR, HEOR in the sense health economic outcome research. This would be most probably applied in pharmaceutical companies, but it is also implemented on ground. It can be implemented by CP also. Like how it would be HEOR nothing but we will be measuring and evaluating the outcomes of our interventions, healthcare interventions for a patient. It may be, it may be regarding quality of life, cost-effective treatment, or correlating with the clinical efficiency that is adding to the patient. So this way, also the CP can improve a patient care, CP presence, and also it will help in promoting the cost-effective treatments and patient-centered outcomes, because every patient will have different complications. So everything need to be like isolated. Different practices need to be implemented for different complications in different settings. So it would be differing. In our settings, we tried with the MICU settings. So this had good kind of impact that I can share. And the key takeaways are like one size doesn't fit to all. See, even a patient have a same kind of infection. I mean, two people are having same kind of infection. it can't be considered like same therapy would work or same regimen would work. No, it doesn't. Even one more thing is the leftover antibiotics need not to be given or continued by the different people. That is also one more irrational practice of consuming or taking antibiotics. So that is one thing. And this is one of the common quote I just came to know. The more we expose antibiotics to microorganisms, the more they will acquire the resistant mechanisms. So this way, there would be at final there would be no choices for treating the infections if you misuse them or if we overuse them. So this is the important, like we need to use them precisely, right sample at right time. This is the importance of diagnostic stewardship. The patient, sorry, the doctor, the intensivist, the microbiologist, CP, and infection control nurse. These all people need to know what is the right time to send. What is the correct sample? What like how can we correct the right sample? Like avoiding the contamination, colonization. So this helps in diagnosing the accurate organism that is responsible for the infection. Then we can target as per our requirement. And next, start smart and then focus. So this is also one more important factor. First, we need to analyze or assess the patient condition. For example, the site of infection, what would be the bacteria that would be involved, and what would be the best empirical therapy, and antibiotic timeouts, and also how many days it need to be given. So these all will help after again generating of getting the culture reports, how it can be changed to the narrow spectrum, which helps in narrowing the therapy and also prevents misuse of antibiotics. So this is one of the method we'll be implementing in AMS. And the new mantra is like shorter is the better. And we have an evidences like many randomized clinical trials are showing that these antibiotics can work very efficiently even for shorter duration. They are showing same clinical outcomes. And if you select a good de-escalating antibiotic with good bioavailability, are also getting same clinical outcomes. So this is also one more thing we need to keep in mind. And finally, prevention is better than cure. See, this is like a post antibiotic era. There are very less antibiotics or new antibiotic molecules that are produced or invented into the market. So that's why it's a time and high time to use them precisely. Uh, if the antibiotics were used whenever they are not necessary, they would not be available when they are necessary. So this is my end note. With that, I conclude my presentation. I'm happy to hear if there are any queries.
Thank you so much, Satya, for that very crisp and clear presentation. I think it was a very vast topic, and within the limited time, you did a fab job at concisely presenting the key points that clinical pharmacists need to be mindful about. So you rightly said that duration of therapy is one of the key aspects of rational antimicrobial use or antimicrobial stewardship. But I'm really interested to know the practical aspect of it, because so when you as a clinical pharmacist go and talk to a prescriber about some recommendations around duration of therapy, how is it usually received by them?
Okay. Uh, During my ward rounds, first I'll be understanding what is the case, and then I'll be assessing that, and followed by I'll be formulating few strategies to deal with. For example, if it is a surgery patient and he is now undergoing to surgery, then I will convey this to the infection control team that if the patient is elective patient for surgery, I mean there would be no comorbidities, no complications for that patient. There would be there is no necessary of going for multiple doses of antibiotic. Only start dose, maximum you can go for 24 hours, like next dose, post dose. So we gave a thought here. It was implemented for only orthopedic department here. We have started the SAP kit. SAP kit, nothing but we will be giving only two doses in that. One dose would be pre surgery, that would be given before the surgery, and one dose if it is necessary, that will be given after the surgery, most probably in the evening. would be like around 6 hours after. So 6 hours or 12 hours after. If the dosing was required, for example, if a patient is having a complication, like surgery is going beyond 4 hours or 3.5 hours, then we'll be asking, then they will be noting that based upon the surgery procedure, we are using this. And if there is any necessary, they will be claiming for next dose. So this way, at least we started an initiative. So this was working, and this is the way even the management is happy with this initiative. I mean, the way
Right.
we are decreasing the misuse of an antibiotics. Yeah, this is one of the practical approach we are dealing here.
So surgical prophylaxis, definitely it has a lot of guidelines that talk about strictly restricting antibiotics within 24 hours of surgery. I mean, not going beyond that. But what about therapeutic antibiotics? You have all these guidelines that say, okay, antibiotics can be given like 5 to 7 days or 3 to 5 days. So you discussed a lot about different foci of infections as well. But when it is a therapeutic infection, when it is a therapeutic antibiotic that you're dealing with, uh, how do you communicate the recommendation? What are some of the references or evidence that you use when you talk to a prescriber to say maybe discontinue the antibiotic or de-escalate to another antibiotic? What are some of the factors that you consider then?
Okay, thank you for this nice question. The thing is, for example, if you take one scenario, this happened in our hospital. The patient was a trauma patient. Here, definitely there would be an exposure of anaerobes too. I mean, the environment, the soil, where they are commonly present. So before, there was only they were given with an ceftriaxone. Even though it is trauma, they used to give only alone ceftriaxone, where the anaerobes were not covered with ceftriaxone. So we, as an initiative, took this stand and asked the surgeon that wherever there is a requirement based upon the bacterial or the bacteria incidence, we need to go for extra coverage. If there is no incidence, we need to decrease the spectrum. So by this, and one more example is, if you are dealing with the orthopedic surgeries, for orthopedic surgeries, alone cefazolin would have good bone penetration, good skin penetration, all these things would be achieved. So there is no such kind of requirement going for ceftriaxone or ceftriaxone sulbactam. So this way we succeeded explaining what is the spectrum, what is the common commensals we are dealing while we are doing the surgery, what need to be covered, what need not to be covered, what kind of extra coverage need to be given, where it is not necessary. So this way we have dealt with the kind of situations, clinical conditions.
Right. And the other thing that I wanted to ask is, what are some of the patient level factors that you consider when you give recommendations around duration of therapy? So why I'm asking is, evidences and publications, guidelines, they stand in one place. And
Yes.
when you go and talk to a prescriber, the immediate thing that most of them say is, see, my patient is sick, the patient is having sepsis, septic shock. How can you say to discontinue the antibiotic? So what are some of the patient level factors that you consider then?
Uh, See, thank you again for this wonderful question. The thing is, we'll be correlating with the patient requirement. For example, if you say the patient factors mainly, a financial factor would be there, and also their kind of, for example, there would be many involvement of doctors. There would be a reference. For example, if a patient was admitted in general medicine, and if there were any involvement of urinary tract infection, again it would be referred to urologist or nephrologist. So the kind of involvement will make an increase in patient economic burden too. And next, if the patient's clinical condition was not identified properly, again it will increase the hospital stay and unnecessary use of antibiotics. So first thing we do is the way we make a figure out of it is, first we ask the patient to, this is again one of the important incident happened in our hospital. Uh, Past medical history is very important, where many hospitals miss that, because the past medical history plays a vital role. Again, I can give you an example with acyclovir induced kind of DRUS syndrome. They haven't mentioned this kind of allergy to acyclovir, but they immediately went with acyclovir. Within after 2 doses, it started DRUS syndrome within the patient, which has increased a patient complication, again hospital stay burden. It is a nightmare for the patient. A complete body was like the skin is peeling off. So this way, first we need to have a good documentation. Documentation plays a main important role. And next, finally, next second step would be a clinical segregation or clinical complete getting a complete idea of what is the diagnosis of a patient, where the symptoms and signs are involved, what is the infection site, and how we can deal with what is the local epidemiology resistant patterns are involved. So this helps in figuring out the accurate drug of choice. Then followed by, after getting an lab investigations or evidences, we will be correlating with an accurate therapy, which is called a definitive or narrow spectrum therapy. So we can minimize this way by segregating each and every step. If you encounter with a systemic approach, then it would be easy to figure it out.
Right. And something that was very interesting in your presentation was where you talked about the fact that, diagnostic stewardship, antimicrobial stewardship, and infection control needs to like go hand in hand, and it should go together for a successful outcome. And I know you are someone, as a clinical pharmacist, you are also involved with infection control practices in the hospital. So I'm just curious to know, like, many a times we as clinical pharmacists think that we don't have a role to play in infection control practices, or we don't know what to do. Probably it's a lack of knowledge because of which we are not going into that aspect. But with your experience, what do you think, or where do you think are some of the areas in with respect to infection control practices that a clinical pharmacist can play a role in?
Yeah. See, in each and every care bundle, for example, if you take the WAP care bundle, there is an involvement of CP. Our nurses will be most probably cross-checking what is the incubation date, extubation date, and followed by what is the flow of oxygen required. So all this would be just monitored or look after, because they will be again having many works or they will be occupied with heavy roles. So here CP can play a role in tackling with clinical aspects. For example, what is the PEEP level? What kind of ventilation is required for the patient? What is the demand, whether it is increasing or decreasing? Whether the patient condition is worsening or improving? Whether the patient is getting good response for the present ongoing therapy or not? And also kind of the hand hygiene practices. It is definitely monitored by nurses only. But the thing is, we also need to monitor as a responsible healthcare professional. We also need to play an important role. Even while we are touching one patient and touching the next patient, we need to know a minimum kind of knowledge, like what importance this hand hygiene can play an important role in stopping the spreading of infections. So this way, a WAP care bundle has importance. If you take surgical site infections and also monitoring the quality team, here the thing is, before here there were no regular sampling of water regarding the body or kind of all these things. But here there was one case where like a patient underwent surgery, open reduction fracture happened. There was an pseudomonas. Like all out, like everyone are fishy how this pseudomonas is there. For example, MRSA would be the common one, or Staphylococcus would be the common one in SSI. But it came out as in pseudomonas. When we asked the quality team what are all the quality checks you are making, then they are missing this water sampling. Then we ordered for water sampling. It was a complete growth for pseudomonas. So this is also one more place where a CP can look into. Uh, the thing is, that pseudomonas can play a vital role, because if we can't figure the source reduction, again it would happen for some other. So in this way, we can even take initiatives in multidisciplinary teams also. The CP role, I won't think like CP's role would be only fixed to a kind of limited boundaries. There is nothing like that. They have good role regarding, we can explore the quality kind of management. We can explore this infection control practices, and also we can explore diagnostic stewardship. For example, same way. One more scenario would be the patient sample was sent to the lab after administration of antibiotic. This was not documented at anywhere. But when I asked the particular person there, Then he said the antibiotic would be given based upon emergency purpose to stabilize the patient. Then samples would be collected after half an hour. So which is a wrong practice, an irrational practice. So this is also one more area where we can look into, and how they are sending the sample. It should be sterile. If you take the mini ball sample, the tip of it, the tip of the cap or tip of the patient tube should
P2
not be
tube.
touched. And here another role is we need to monitor how the nurses are collecting the sample. So this way we have multiple roles to take care of, and this way we can get involved in many aspects, and we can give our best.
I hope the participants who are listening to the presentation today are making a note of these points because, like Satya rightly said, clinical pharmacists have a lot of scope here, and we need to think outside the box and look for opportunities where we can contribute. And another thing that he rightly pointed out was also measuring the outcome of your interventions, which is also very important. Whatever interventions that you're doing, make sure that you're also measuring its outcomes. So I think we are done with the presentation and questions. So thank you so much, Satya, for that amazing presentation and for giving us a lot of insights from your experience. I think you have a few more slides as conclusion on our upcoming
Yeah.
events. And yeah, you can conclude the presentation. Thank you so
I
much.
just want to inform to the audience. Yeah, I just want to inform to the audience that upcoming module on basic module in research and publication, it is an evidence-based medicine that is going to be held on April 21st. The speaker would be Muhammad Rashid, sir. And next one is septic shock. The topic is septic shock from critical care forum on April 26th. And the speaker is Hussein sir. And next on 27th from ID forum, Dr. Nishala Reddy is taking an antimicrobial allergies. And the final module of this month, final session of this month on 28th April from ID forum is clinically significant antimicrobial interventions by Dr. Aisha Shana. So stay tuned, and you'll be definitely having a good content to learn, and also we can meet great expertise. Yeah, thank you for your time. Thank you for being here so patiently.